and welcome to the second in a series of webinars on the topic of liquid biopsies and ILC. My name is Barbara Nielsen, and I'm a founding member of the Lobular Breast Cancer Alliance. I've been an active volunteer on their research committee and a recent member of their Patient Advocate Advisory Board. I'm honored to be here today to host this webinar on behalf of LBCA and to welcome our panel of presenters. Today, we'll hear from three presenters on their perspectives in research in the field as it pertains to liquid biopsy and early stage ILC. First, we'll hear from Dr. Megan Kruse, a breast medical oncologist and director of breast medical oncology, co-lead of the breast cancer program, and medical director of Taussig Cancer Center Clinical Trials Office at Cleveland Clinic. Then we'll hear from Dr. Rinath, a breast surgical oncologist and professor of clinical surgery at University of California, San Francisco. And last, we'll hear from Dr. Rinath Jeselsohn, a breast medical oncologist at Dana-Farber, assistant professor of medicine at Harvard, and associate professor of medicine at Brigham and Women's Hospital. Additional biographical information can be found about our presenters on the LBCA website or the cover page of this webinar. This is an evolving area of study, and we hope that this webinar will provide additional information so that you can have informed discussions with your care team. Before we get started, I was asked to help because I have personal experience with liquid biopsy. And so here's my story. I was diagnosed 9 years ago. No signs, no symptoms, no family history, but a routine mammogram found a suspicious area and a tissue biopsy confirmed it. I had several different medical and surgical opinions before treatment, and they all said very small, no lymph node involvement, stage 1. And I thought, not too bad. However, as is often true with lobular, the cancer was twice as large as shown on imaging, and it had spread to the lymph nodes. So when I woke up from surgery, I was stage 3. And the manageable small little cancer was now going to require some major changes in my life. At that time, there was almost no information about ILC, and I quickly learned all I could and joined up with this starting organization, the LBCA. I came to realize that my cancer was a different type than the more common hormone-positive cancer, and that it is hard to diagnose. It doesn't show up well on imaging, and lots of people are underdiagnosed. As far as my treatment, I was really busy. I had lots of surgeries and follow-up. I had a blood clot. I had all kinds of chemo and radiation. And so I was really busy. And then it all came to a screeching halt. And I felt kind of like, ooh, now what? I came back for a checkup for 6 months. I saw the radiologist. I saw the oncologist in 6 months. And it was really, we sat and talked. There wasn't much as far as follow-up. And I was told that if something really hurts me for 2 weeks in a row constantly, well, maybe then you need to call and get a medical appointment. But this felt like, well, if I didn't feel any pain before and I was stage 3, why would I feel pain now if there's a recurrence? I hated the idea of thinking that I had to wait till it was a major medical issue or an emergency, and I couldn't catch a recurrence when it was small. I changed doctors and began seeing Dr. Kruse. She suggested that I have a liquid biopsy every 6 months, and I was really glad that there might be something to catch early stage recurrence. It's a simple blood draw that looks for residual disease in my bloodstream. In my case, we discussed that a high count would warrant repeating the biopsy every 3 months. And if the count was still high, then we'd add another drug to the anastrozole I currently take. 9 years ago, when I was diagnosed, they didn't have the CDK4/6 inhibitors. They're now given to stage 3, but they're given right after surgery and not years later, as would be my case. So our decision was that, okay, I could add the CDK4/6 inhibitor, and that would be the time for additional testing like the PET scans and the CAT scans and so forth. Originally, I was told that the MRIs, the PET scans, those things wouldn't be necessary because they lead to a lot of false positives, a lot of testing, a lot of worry, very expensive, and in and of themselves, repeated tests can be harmful. So just to sort of summarize, I think that having the liquid biopsy gives me some stress management, peace of mind, and I know I have a plan if my current treatment regimen stops working. I like the idea that I'm being proactive and I'm sort of addressing that cloud that hangs over all cancer patients when they worry about recurrence. Also keep in mind, late recurrence is more common with ILC, and late recurrence means it can return 5 years or even 10 or 15 years later. So I feel like liquid biopsy is really giving me something to feel like I am handling my disease and not waiting for some major symptoms to reveal themselves. That's my story. Thank you for letting me share my experiences. And before we move on to our first presenter, I'd like to just say that I'll be facilitating the question and answer presentations. So add your questions to the chat box as the seminar is on. And at the end, we'll address as many of them as we can. Just remember that you can't have any personal issues addressed. And now, time for Megan. Thank you.
Thank you so much, Barbara. I'm just going to get my slides shared here. So as I share these, let me all know. Can you see them? Looks good? Okay. So again, thank you for having me today. As Barbara said, I'm a breast medical oncologist at Cleveland Clinic, and I'll be talking a little bit about the use of ctDNA in early breast cancer in general. And then I think as our program progresses, we'll talk more lobular specifics and certainly get into that during the question and answer period. And I will tell you that I think this is one of the hottest and most controversial topics in all of breast medical oncology. And if you ask 10 medical oncologists their opinion on this, you are going to get 10 different answers. There's no question about it. And so I don't know that we'll come out of today with a path forward for how we should all be doing this, but I think today's discussion will really lead to questions that you can bring up with your own medical oncology team or the people that you work with, and have an eye towards where we might be going with this testing in the future, because this is one of the early times where we have testing available, but we're not entirely sure how we should be using it. So part one of this webinar, I'm sure many of you attended and have watched it. It was really a wonderful introduction to ctDNA. So I don't want to repeat all of that in the interest of time. But for those of you who were unable to attend that part of the webinar, I wanted to just give you a little bit of background about what circulating tumor DNA is, and the types of platforms or types of tests that we have at our disposal. So in general, what we're doing with ctDNA or circulating tumor DNA is we're taking a blood specimen or blood sample to look for DNA that has gotten out of cells. And we know that in the everyday course of our lives, as different cells in our body are dying off and being replaced by new cells, the DNA as they die from that cell is released into the blood. And the same thing happens with tumor cells. And so on the right-hand side of the slide, that's what you're seeing, is that the idea is you would have a tumor in the breast, or it has been removed and there may be tumor cells still in the body. And as those cells die off, they release their DNA out into the blood. But when we get that blood sample for circulating DNA, we're not just getting cancer DNA, we're getting that normal body DNA as well. So if you look at this picture where the little green DNA swirly strands are in that blood vessel, that would be your normal body DNA from normal turnover of cells. And where that red sample is, that would be the cancer DNA. And so just to get an idea, we're getting kind of a picture of everything that's going on in the body, hopefully, with this blood sample, rather than when we get a biopsy from, say, a tissue site, like going into the bone, going into the liver, where whatever we get out in that needle is really only reflective of that one site in the body. And so the applications for ctDNA, there's lots of different things that people are thinking about of how we can use this technology, everywhere from improved screening to getting a better sense of if our treatments are working both before surgery and after surgery. A lot of what we'll talk about, at least in my part of the presentation, is this concept of minimal residual disease, which is really how are we looking for cancer that may still be in the body after a patient has received their appropriate surgery, radiation if needed, chemotherapy if indicated, and for most of our patients with lobular cancer, also their anti-estrogen-based therapies. And when we order tests like this, we have options, and I think those options are only going to expand over time. Right now, we have two general different types. One is called tumor agnostic, and one is called tumor informed. Tumor informed is the one that I think is a little easier to explain. That is where we take a sample of the original breast cancer and use that as sort of a template or a guide for the type of DNA that we're looking for in the blood. And there's some pluses and minuses to this, right? It's a more personalized approach, but also if the cancer over time starts to look different from its original form, it might be harder to detect that in the blood. And these tests tend to take more time because there's a whole manufacturing process of using the original tissue and getting it to look like what we're looking for on subsequent tests. And then the tumor agnostic are tests that are not specific to your own tumor, but are be looking for general breast cancer characteristics. So the turnaround time is faster, but it may pick up cancers if they look different from their original form. And what might the results look like? Here's just some general examples actually from the Exact Sciences website. They have a test called OncoDetect, but I think this is a good example of what you might expect if you had one of these tests done. When we talk about the results, we'll call it either negative or positive. Negative in this space is actually the good result. So even though we say it's negative, it means a good thing, which is that the cancer DNA cannot be detected in the blood. And a positive result means the cancer DNA can be detected. So on the left-hand side of this slide, you can see a result where the patient started with detectable cancer DNA in the blood right after their surgery. And then over time, as the test was repeated, we saw that level go down and down to the point where about 6 months after they had their surgical treatment, the cancer DNA was not detected in the blood and it remained that way. And you would contrast that to the patient on the right who initially did not have cancer DNA detected in the blood on this graph. And then it goes up, it reaches a little peak, and then it goes back down. So hard to know what happened there. Did it do that on its own? Did we do a different intervention or treatment? But then it stayed negative for a while and then started to go up again. And so the other thing here is you can see that when the test is positive, typically we get some sort of estimate of how much cancer DNA is there with a number, and we can track that over time. So the clinically available tests, I've included 3 here. Signatera, which is the tumor-informed ctDNA test from Natera. OncoDetect, which is the tumor-informed ctDNA test from Exact Sciences. And Guardant Reveal, which is the non-tumor-informed, more general breast cancer DNA test that is from Guardant. And as of right now, Signatera, to my knowledge, is the only test that is called out in the Medicare coverage guidelines. In that red box there, you'll see that it can be covered for patients with stage 2 to 4 breast cancer in the neoadjuvant setting, so meaning while a breast cancer is still known to be in the body, and maybe we're looking to see how well treatment is working. But it can also be used in stage 2B and higher breast cancer in the adjuvant setting, so after surgical management, for recurrence monitoring. Now, the trick here is this is just Medicare coverage, right? So that is going to be a certain segment of our patient population. It's much harder, although commercial insurance guidelines often follow Medicare coverage guidelines. We still have limitations in where we see commercial insurances now paying for these tests. And so that is something that we can get into in the question and answer period, but tends to be a limitation for many of our patients. If they don't have insurance coverage, the tests can be expensive. Right now, a lot of the general coverage for these types of tests really lies in the colorectal cancer space. And that's really because of the evidence that we have out there that doing this type of testing changes management and changes cancer outcomes. So what do we know so far about ctDNA in early breast cancer? Essentially, we know that if you can find it, it's a bad sign that cancer recurrence is likely to happen. and that the recurrence that is likely to happen is going to be one of those metastatic or distant recurrences, where we're finding the breast cancer show up in other organs of the body, like bone or lung or liver. And this is one of the earlier publications from 2022, a small study. A lot of the studies that we have out there are going to be somewhere between 50 and 100 patients. But essentially, for the patients that had detectable cancer DNA in the blood, in this particular study where they had received all the planned treatment for their breast cancer and were on the ongoing endocrine therapy, that about 10% of patients tested positive for the cancer DNA in the blood. And that positive test tended to occur about a year before patients were found to have evidence of the cancer spread on standard imaging, whether that was CAT scan or PET scan or whatever was recommended to the patients. On the right-hand side of this slide, this is a little bit of a complicated plot that we call a swimmer's plot. And basically, each one of these lines represents a different patient. And the ones that are highlighted here in yellow are all of the patients that have had recurrences. And the ones that have these dark filled in lines are the patients that had positive ctDNA. So you can see that almost all of the patients with positive ctDNA in this upper portion here all went on to have true detectable metastatic recurrences. But even one of the patients with negative ctDNA had a recurrence that was found on imaging over time as they were being followed. So a negative test clearly, at least at this point in time, doesn't mean you're totally out of the woods, but a positive test means we're very concerned. And we have limited data about what these tests mean for our treatment outcomes, but I wanted to show you some information from a few clinical trials. The first one here is from Monarch E. So what that trial was designed to do was intensify treatment for our patients with high-risk breast cancer. These are node-positive, hormone-positive, HER2-negative breast cancers in general. And the patients here received either their standard anti-estrogen treatment or that anti-estrogen treatment plus a drug called abemaciclib, which many of you may know as Verzenio, that you've heard has since been approved for improving survival for our patients that fit this criteria. So this was a much larger study in general. There were over 5,000 patients, but almost 900 of these patients actually had blood collected for ctDNA assessment with Signatera. And what we know is that the ctDNA was positive overall for about 8% of patients in this study before they received their anti-estrogen treatment or the abemaciclib. And among those patients who were ctDNA negative at the beginning, it was pretty rare for patients to become positive while they were on treatment. That was only about 10%. But for patients who started positive, about 41% of them became negative over time with their treatment, and 59% stayed positive with these subsequent treatment samples. And what we found is for those patients, so now I'll direct your eyes to the right-hand side of the slide here. For those patients who were always ctDNA negative, they're represented in the blue upper bar here. And the flatter this line, the better their survival. What this curve shows is the time over which these patients were alive and living well and without cancer. And so for the patients who started negative and stayed negative, they had a really high chance of staying close to that, living without any evidence of breast cancer over time. This next line here, that did well but not as well, are the patients who started positive and became negative over time. So what you're thinking there is that this treatment is doing something to help prevent those patients from developing metastatic disease, really clearing out cancer cells. And then the patients that are in these two lines that aren't so good, these are patients that are developing cancer recurrences pretty quickly, and many of them, unfortunately, are going to ultimately pass away from those recurrences. These are the patients in the red line that started negative and became positive, and the patients in this gray line are those who were always positive. So clearly, positive is a bad thing, but if you start positive and become negative, maybe we're influencing what happens with your treatment outcomes. And the types of recurrences that we're presenting, which is shown over here in red, it's really those spread other parts in the body, those distant recurrences. So we're not really impacting necessarily the risk in the breast or the other breast, but it's really that risk traveling, cancer cells traveling through the blood and going other places. And then I think this DARE study is really interesting. This is a study that was presented at ASCO in 2025, really looking at patients who, if they start on standard endocrine therapy and are found to have positive ctDNA, can you change that therapy, that either the endocrine therapy or add something, and change what happens with the cancer? So lots of details here, but I will tell you these are high-risk patients by lymph node involvement or high-risk molecular tests like Oncotype or MammaPrint. They had been on endocrine therapy for at least 6 months, so you knew that they didn't recur immediately, up to 7 years, and they had ctDNA monitored every 6 months. And if the ctDNA was positive, then the patients that were positive either stayed on their same therapy or switched to a different type of endocrine therapy with the addition of one of those CDK4/6 inhibitors here called palbociclib. So only about 12% of patients in the study were ctDNA positive over time. And actually about a third of patients who had positive ctDNA already had metastatic disease on scans when they were found to be ctDNA positive. So we all hope that ctDNA is the first thing you find before the cancer's actually established itself in other organs, but that's not necessarily true. And we don't have the long-term follow-up results of this study, but what we do know is that for those patients who had ctDNA negativity and stayed negative, they had almost 100% chance of being cancer-free over many years. And for those who had clearance of their ctDNA on treatment, whether it was the standard or this change in endocrine therapy with the addition of palbociclib, that they tended or the patients, I'm sorry, let me rephrase that. The patients who had clearance of their ctDNA after switching therapy, it was more common to see that ctDNA go away when you were on this new endocrine therapy, fulvestrant with palbociclib, versus staying on the same endocrine therapy. So we hope that means that these patients stayed cancer-free in the long term, but that's actually what we are not sure of right now. So in the interest of time, I'm going to skip the additional data that we have here, and that will be available to you all later on. But there are a ton of studies in this space. There are over 300 trials like this listed on clinicaltrials.gov. And one that's very interesting and coming up is the TREAT ctDNA study, where it's looking at a new oral anti-estrogen called elacestrant. We'll be looking for the follow-up results from that DARE study I just showed you and the LEADER study, which is very similar but uses a drug called ribociclib rather than palbociclib. And so to get to the idea of how do I use these tests, it's all individualized patient discussion. Basically, when I'm sitting down with a patient, much like what you heard from Barbara in the conversation we had, my overall question is, will this information be helpful or harmful? How would we use it to change treatment? Because right now we don't know that changing treatment is actually going to lead to better cancer cure or better survival. We hope that's the case, but we don't know it. So for right now, we're a little bit unclear. We can change things, but will it actually do anything for our patients? And will it be associated with any harm, right? So that could be extra imaging, greater co-pays, cost of testing, more side effects. There's lots of different things that can fall under harm. I think a lot about, will these tests be helpful in the sense that they create less stress because, like Barbara said, it gives her some control, some peace of mind, or are they going to add to stress and give you less control, where you feel like if you have a positive test, you're worried about it all the time and it's taking away from your quality of life. The other thing is these tests aren't perfect. You'll have false positives, false negatives. Will patients make decisions based on a negative test where they stop therapy when we don't really know that's the right thing to do? Clearly, we know that patients with negative tests aren't out of the woods and still are at risk of recurrence. And if there's a false positive, will that lead to a patient being more aggressive or being more concerned when we don't really know that that test is a true positive? And then there's a bunch of logistical questions. Which test, how frequently, when do we stop, when do we start, how is it paid for? We don't know the answers to any of this. But the one thing that is clear is if testing is done and it's positive, we must go do scans of the body because there's a good likelihood that metastatic disease will already be found. And if we find ourselves in the situation where we have a positive test and negative scans, that's where we start to say, should we add additional treatment? Right now, the best answer might be getting involved in one of these clinical trials like DARE that is still accepting patients who have positive ctDNA tests and negative imaging. And with that, I will stop here and pass to our next presenter, who I believe is Dr. Mukhtar.
Yes, thank you so much, Megan. My name is Rita Mukhtar. I'm a breast surgical oncologist at the University of California, San Francisco, and I will start sharing my slides in just one moment. Okay. So I am going to actually be talking about a potentially novel use of ctDNA. I think the entire field is novel, but thus far, most of the uses have really been focused on detecting disease for systemic therapy management and potentially diagnosing recurrence. And this talk is actually some data that I presented at ASCO last year, really asking the question, is there a role for ctDNA to help us tailor the surgical treatment that we offer patients for breast cancer? So as a little bit of background, as we heard from Dr. Kruse, we know that there are different kinds of ctDNA tests, and the older ones are typically referred to as genotyping assays. And so this would be something like a Guardant 360, where you're looking for a specific mutation that might be present in a tumor. Then we have these newer tests that are called MRD assays, or molecular residual disease, sometimes called minimal residual disease assays. These are more sensitive tests that are not necessarily looking for a treatment target, but rather are looking for evidence that there is presence of tumor somewhere in the body. So the older tests, which are still in use today, can be used to find a treatment target, and this is telling us about the genetic landscape of the tumor, whereas these more sensitive MRD assays can tell us that there is cancer somewhere in the body, and that can help with prognosis and maybe with telling us that there's treatment resistance. But what we really wanted to look at in the study that I'm going to be sharing with you is, can you also use these MRD assays to plan the type of surgery that we would do? And this slide is really summarizing what I'm about to show you. So we know that patients with breast cancer often have to have lymph nodes removed. And if you remove too many lymph nodes, for example, the type of surgery called an axillary dissection, this can cause permanent swelling of the arm, which is termed lymphedema. For people who undergo chemotherapy before surgery, which is called neoadjuvant chemotherapy, it can be difficult to determine how many lymph nodes should be removed. So we often end up doing these full axillary dissections, maybe in people who didn't actually need it, but we didn't know it until the surgery was already done. We were able to find some preliminary evidence that ctDNA can help to predict more accurately whether there are just a few lymph nodes or many lymph nodes that contain cancer after chemotherapy. So I think that there's really promise that ctDNA could help to potentially reduce the extent of lymph node removal. And of course, that this would imply that we might be able to plan other aspects of the surgery as well. So a little bit of background about how lymph nodes are currently treated for patients with breast cancer after neoadjuvant chemotherapy. And these data are not specific to lobular breast cancer, but this is also true for those with lobular breast cancer. This graphic is representing the lymph nodes in the armpit area, where each little beige oval is a lymph node. These are the axillary lymph nodes. And typically, patients will have either sentinel lymph node surgery, where between 1 and 3 lymph nodes are removed. And sometimes, if we already know that there's a specific lymph node that we want to remove, that would be called a targeted axillary dissection, where you're still just removing a few lymph nodes. And currently, if any of these lymph nodes have cancer after neoadjuvant chemotherapy, the standard of care is for patients to undergo removal of 2/3 of the remaining lymph nodes. And this is called axillary lymph node dissection. And when we do this, we can actually give patients a risk of lymphedema that is up to 40%. So let's look at some examples of how this might actually happen for specific patient situations. So this graphic is representing a patient who has multiple lymph nodes that have cancer. So the red ovals are lymph nodes with cancer. In this situation, the surgeon would remove just a few lymph nodes at the initial procedure, and they would get 3 out of 3 positive lymph nodes. The patient would then be told, you have to go back to surgery, remove more lymph nodes with the axillary dissection. That would remove these additional lymph nodes, And now we would have 4 more positive nodes, or 4 out of 8 positive nodes. This patient would have what's called a high nodal burden of disease. In contrast, say we have a situation like this, where this person only has 2 positive lymph nodes, but we don't know that until the surgery is done. So this person would undergo sentinel lymph node surgery. We would see 2 out of 3 positive lymph nodes. Because there was even 1 positive node, the person would be told, we need to go back and remove more. The surgeon would go back, remove 8 more nodes, and all of them would be clear. So this person in total has only 2 positive nodes, or a low nodal burden. And had we known this, this person probably shouldn't have had that extra surgery to give them this risk of lymphedema. There's data that was represented at San Antonio in 2024 from an ongoing trial showing that among patients who have 1 positive sentinel lymph node after neoadjuvant chemotherapy and then undergo a completion axillary lymph node dissection, over half, or 54%, had no additional positive nodes. So we really need a better way to determine how many people really need to have that second surgery and that removal of those remaining lymph nodes. So we hypothesized that we might be able to use ctDNA to predict that. And we looked at this question in a trial called the I-SPY trial. And the I-SPY trial is a neoadjuvant trial that is open at over 40 centers across the United States. So in this particular analysis, we were looking at patients who had what's called high-risk breast cancer based on a test called MammaPrint, so molecularly high-risk breast cancer. And patients on the trial receive neoadjuvant chemotherapy and then have surgery. And while they're on neoadjuvant chemotherapy, their ctDNA is measured before starting treatment, 3 weeks after treatment, 12 weeks after treatment, and then finally after finishing all of the chemotherapy and before going to surgery. And the ctDNA on this trial is measured using the test called Signatera, which Dr. Kruse had mentioned. We looked at 493 patients who had test results available before chemotherapy and after chemotherapy. And we also looked at other characteristics such as the patient's age, the size of the tumor, which is called the T category, whether we already knew that the lymph nodes had cancer involvement before starting treatment, so that is the N category. We looked at the hormone receptor and the HER2 status, and of course, we looked at whether the ctDNA was positive or negative before and after starting treatment. And we did use some complicated statistical modeling with machine learning, and I'll skip through this, but essentially we used machine learning to create a predictive model to see if we could better predict at the individual patient level the chance of having multiple positive lymph nodes after chemotherapy. So of the 493 patients, the average age and characteristics are shown here. The patients in this study are on the younger side with an average age of 48 years at diagnosis. 72% had T1 or 2 tumors, so tumors that were smaller than 5 centimeters. Just over half had lymph node involvement that was already known about before starting chemotherapy. A third had triple negative tumors, a quarter had HER2 positive tumors, and then the remaining 43% had hormone receptor positive, HER2 negative breast cancer. And most of the patients with lobular breast cancers would fall into that category. And this pie chart is showing how many patients were ctDNA positive before chemo and then after chemo. And so the large gray section of this pie chart is showing that the majority of patients, so almost 70%, actually had detectable ctDNA, so they were positive before chemotherapy, but thankfully were able to clear the ctDNA after chemotherapy. 19% were negative the entire time, so both before and after chemotherapy. And then about 9% were positive for ctDNA, and that ctDNA was not cleared by the chemotherapy. And a very small proportion actually developed ctDNA positivity over the course of treatment. And this is showing, when you look at these broad categories of which patients had persistent ctDNA positivity, these are patients who at diagnosis had larger tumors, had more nodal involvement, and this persistent positivity was more common in patients whose tumors were either triple negative or very high risk based on this test called MammaPrint, so MammaPrint high 2 status. there were about 12% of patients who had a high nodal burden, even though they went through the chemotherapy. And we looked to see, does the ctDNA clearance associate with having this high nodal burden? And when you look at these four categories of people who were negative, people who were persistently positive, people who cleared ctDNA, and people who became positive for ctDNA, there is a statistical association where in the orange part of the bar graphs, these are patients who had high nodal burden or many positive lymph nodes after chemotherapy. And you can see that in patients who were persistently positive, almost 40% had this very high nodal burden. So there is an association between the ctDNA positive nodes. But this kind of association is not super helpful for telling a specific patient, in your case, what are the odds that you will have many positive nodes left? So should we do an axillary dissection in you or not? So to do that kind of analysis, this is where the machine learning algorithm comes into place. And what we did was we created this predictive model where we gave all of the information to the model. We trained the model on a set of patients where we said, okay, this is how many of these patients had multiple positive nodes. These patients had very few positive nodes. Can you make a prediction for each individual patient? So what we're seeing along this horizontal line here, or the x-axis, is actually each of the individual patients in the study. And the higher this vertical line is, the higher the probability that the machine learning algorithm gave us. So if the line is towards the top, it's saying that we predict a very high chance that this particular patient will have multiple positive lymph nodes. And then the color is telling us sort of the truth. So what did the pathology actually show? So in blue are the patients who actually had very few positive nodes, so fewer than 4, only between 1 to 3 positive nodes, or even no positive nodes. And the pink are the patients who had 4 or more positive nodes. So this is not perfect predictor, but the higher the prediction, the more of these pink lines we see, and the lower the prediction, the more of the blue lines that we see. So we're getting closer and closer to being able to predict at the individual patient level. And the way that the accuracy of the prediction is measured is by using something called this area under the receiver operating curve. And that value came out at 0.83. Closer to 100% would be perfect prediction, and 0.83 or 83.7% is considered good predictive ability. So then we wanted to say, well, what is the machine learning algorithm using to make the prediction? Is it using the patient's tumor size? Is it using the hormone receptor status? Is it using the ctDNA at all to make the prediction? So to do that, we actually can split patients into these buckets and see what's the chance of high number of positive nodes in each bucket. And that is called building a recursive partitioning tree. So we didn't create the tree. We asked the algorithm to tell us, what are you using to make the prediction? And the algorithm said that the most important predictor was whether or not the patient started out clinically node negative or clinically node positive. So if you start out with clear lymph nodes based on imaging and physical examination, that was a big split kind of in the group of patients compared to people where we already knew that they had lymph node involvement. So let's go down this branch of the tree of looking at patients where we didn't know that they had any lymph node involvement. For those patients, the next most important predictor was the size of the tumor. So patients with smaller tumors versus patients with bigger tumors at diagnosis. Amongst those who had smaller tumors at diagnosis, which is called T1 to 2, the next most important predictor was, in fact, the ctDNA. So we can see here that ctDNA is going to be positive or important for these patients, where if it's positive, these patients had a very high likelihood of having multiple positive nodes, even if we thought they were node negative and even if the tumor was small. For patients who had larger tumors at diagnosis, the ctDNA was not a useful tool to predict the chance of having high nodal burden. And here at the bottom in these sort of turquoise squares, we can see what proportion of patients actually had multiple positive nodes. So even though the ctDNA positive group was higher than the other groups, it was still only about 10% of these patients had high nodal burden. Now let's go down the other branch of the tree and look at the patients who started out with positive nodes. So this is the clinical node positive group. In this group, what we found from the machine learning algorithm is that the most important predictor of how many positive nodes remained after chemotherapy was actually the ctDNA. And if we go down the ctDNA negative group, next most important was the tumor size at diagnosis, then was the tumor receptor status, hormone receptor status, HER2 status, and then finally here we can see how many patients actually had multiple positive nodes. If we go down the ctDNA positive group, we can see that tumor size does matter and hormone receptor status also matters. And this bar graph is looking at these groups that the tree was able to split. The tree created 12 distinct groups. And in these groups, you can see the numbers in the bar graph is showing what proportion of patients had high nodal burden. And we can see on the far right here, and I'm just going to skip to this part here. I know it's a complicated slide, but if you look at these groups to the right of the green dashed line, these are patients where at least 30% or more had a high nodal burden. And most of these patients were ctDNA positive after neoadjuvant chemotherapy. And then we have this middle group where they were ctDNA negative, where the chance of having a high nodal burden ranged from 7 to 15%, except in one instance. And I think that this is relevant for patients who have lobular breast cancer. If you look at what is group 8 right here, these are patients where they were ctDNA negative after chemotherapy. But in blue, we can see that a third of them still had 4 or more positive lymph nodes after chemotherapy. And when we look more closely at who are these patients, we see that these are patients who started out with large tumors bigger than 5 centimeters at diagnosis, and hormone receptor positive. And we know that most of our lobular patients in this trial fall into this category. So this is somewhat disappointing because this is suggesting that the ctDNA predictor can be helpful for patients with other tumor types, but perhaps not as beneficial to predict for patients with lobular breast cancer. So again, identifying a great need to further refine our ability to predict what are we going to find at surgery for patients with lobular cancer. Finally, this is just showing some of the statistical attributes of the test and showing that the test does have high negative predictive value. So if it's a negative test, there's a good chance that there's not many positive nodes, with the exception, again, of those clinically node positive patients with hormone receptor positive tumors where the test doesn't do as well. But in summary, what we were able to show with this analysis is really a new use or potential use of ctDNA. So risk stratifying, using the ctDNA to help us plan what kind of surgery we might actually do, and hopefully spare patients surgery that could be harmful without actually helping them, such as taking out normal lymph nodes because we otherwise weren't able to know that they were going to be normal. Of course, this is retrospective data. This would need to be validated prospectively, and we definitely need to study this specifically in patients with lobular breast cancer, where there's really a huge need to be able to make better prediction about what we're going to be finding at the time of surgery. So I will stop here and answer questions about this at the end, and turn over the presentation to Dr. Jeselsohn.
All right.
I'll share your slides.
All right, thanks. So my name is Rinath Jeselsohn. I'm a breast oncologist at Dana-Farber, and I'm going to share with you a little bit of a different aspect of ctDNA in early stage disease, also in the setting of neoadjuvant treatment, but actually in the setting of neoadjuvant endocrine therapy in hormone receptor positive breast cancer only. So next slide. So just in general, when do we use neoadjuvant therapy in breast cancer? And neoadjuvant therapy means that patients get upfront systemic treatment, and then after that period of systemic treatment, go on to surgery. instead of having surgery up front and then systemic therapy afterwards. And in HER2 positive breast cancer and triple negative breast cancers, there really are two main reasons why we do neoadjuvant therapy. One is in cases where we want to downstage the primary tumor, meaning making the tumor smaller to enable either a smaller tumor or make sure that the margins of the tumor are negative, and also to downstage surgery for the lymph nodes, as Dr. Mutkar has mentioned. In addition, for HER2 positive breast cancer and triple negative breast cancers, we use neoadjuvant therapy in many cases, and that's because we can tailor the treatment after surgery based on the responses to neoadjuvant therapy, looking at what is the residual disease or what was the response to the neoadjuvant therapy. However, in hormone receptor positive breast cancer, really the main reason we use neoadjuvant therapies is because we want to, in cases where we want to downstage the primary tumor or the lymph nodes. And we have two options. We have the option of using endocrine-based therapy as the neoadjuvant therapy or chemotherapy, and this decision is based on molecular features of a cancer or other risk features where we make this decision. But in general, in hormone receptor positive breast cancer, the response to neoadjuvant therapy is not really indicative of long-term outcomes, and therefore we don't use neoadjuvant therapy to tailor treatments at this time. Next slide. So we have conducted here at Dana-Farber, and this was a multi-center study called PLOPS, which was a phase 2 randomized trial of neoadjuvant palbociclib, which is a CDK4/6 inhibitor with or without, it's actually neoadjuvant endocrine therapy with or without palbociclib for breast cancer, including invasive lobular cancer or invasive ductal cancer. So in this study, patients were randomized. It's a quite complex study, so I won't go through all the details, but patients were randomized initially to tamoxifen versus letrozole for a short period, and then re-randomized to palbociclib plus endocrine therapy or endocrine therapy alone, and then went on to surgery. But what's important about this study and unique about this study is that patients were stratified based on their histological subtype. So about half of the patients in this study had lobular breast cancer, and half of the patients had ductal cancer or invasive breast cancer of non-specific subtype. And if we go on to the next slide, and in the presentation today, I'm going to talk about a translational or correlative study that we did as part of this clinical trial, and that's the circulating tumor DNA study, where plasma was collected at baseline pre-treatment, and then after neoadjuvant endocrine therapy plus or minus the palbociclib prior to surgery. And this study was, and this part of the study included a subset of patients, a total of 52 patients. And in this study, we used a tumor agnostic assay. As mentioned before, tumor agnostic means that we didn't use the tumor tissue itself to identify specific genomic alterations in order to detect circulating tumor DNA. Rather, this uses a signature based on DNA methylation. And for patients that had DNA methylation positive or circulating tumor DNA, we also performed sequencing to look at specific genomic alterations. So next slide. And the aim of this study, the aims included, first, we wanted to know, can we detect, and at what frequency can we detect ctDNA in plasma from patients with early stage hormone receptor positive breast cancer, particularly because hormone receptor positive breast cancer shed relatively low amounts of circulating tumor DNA, and therefore overall it is harder to detect ctDNA in patients with hormone receptor positive breast cancer, and let alone in patients with early stage hormone receptor positive breast cancer, where overall the tumor burden is relatively much lower compared to a patient who has metastatic disease. And also the other reason that it was important for us to perform this study and look at the frequency is because we were using a tumor agnostic assay. The other question we asked was, and this goes back to Dr. Mukhar's talk as well, we asked, can baseline ctDNA correlate with the tumor burden at the time of surgery? Meaning if we can, if identification of ctDNA prior to neoadjuvant therapy can help us can inform what will be the tumor burden actually at the time of surgery, and that can help us decide if a patient would benefit or not benefit from neoadjuvant endocrine therapy. We also wanted to test if ctDNA dynamics, meaning the changes in ctDNA from the time of pre-therapy to the time of pre-surgery after the therapy, or ctDNA at the time of surgery, is it prognostic? So can it give us information about long-term outcomes? Next slide. So this is just some of the patient characteristics, and I know this is a busy table, but I just wanted to highlight a few points here. So majority of the patients in this study had lobular breast cancer, and in addition, overall, these patients were not high-risk patients and did not have very high tumor burden. And if we go on to next slide. So these are some of the results. First of all, we were able to detect ctDNA in 38% of patients at baseline. And when we looked at the correlation between the detection of ctDNA and the residual cancer burden, or RCB, and RCB basically is based on both the tumor size and lymph nodes, we saw that there was a significant correlation between the detection of ctDNA as well as the level of the ctDNA, or the tumor fraction that was identified in the ctDNA. And if you click, sorry, there's an animation. Oh, okay, so I'm sorry, I was missing something in the slide, but but what we did see was that if we looked at ctDNA on baseline, what the correlation of ctDNA at baseline was mostly with actually lymph nodes, positive lymph nodes, or the lymph node burden at the time of surgery, and not so tumor size. So that was an interesting finding, but again, supports the idea of being able to use ctDNA as a tool to help predict lymph node burden. Next slide. And then the other thing we looked at was tumor DNA at ctDNA at the time of baseline, so before endocrine therapy. Can it help us predict outcomes? And you can see here that patients that had positive ctDNA, or patients who had, based on the tumor fraction of the ctDNA at the time of baseline, those that had higher tumor fraction were more likely to have a recurrence versus those that had lower tumor fraction. However, if we dichotomized the ctDNA results to detected versus non-detected, that was not significantly associated with long-term outcomes. Next slide. And then when we looked at ctDNA at the time of surgery, so after the neoadjuvant endocrine therapy, again, we saw that the tumor fraction was associated with recurrence versus non-recurrence, but in addition, ctDNA detection versus non-detection was associated with outcomes, and patients who had detected ctDNA at the time of surgery after neoadjuvant therapy had worse outcomes. We also looked at the dynamics, so next slide. So ctDNA dynamics, meaning changes in ctDNA from baseline to the time of surgery. And we identified three subgroups of patients. So there were patients that had persistent ctDNA or emergent ctDNA. So meaning persistent is that they had ctDNA detected at prior to treatment, and it persisted and was seen prior to surgery. And then emergent are patients who didn't have ctDNA detected at time of baseline, but did have ctDNA detected at the time of surgery. And as you can see in this table, actually we did not identify patients who had emergent ctDNA. We did see patients who had cleared ctDNA, meaning that at the time of at baseline we could identify ctDNA, but at the time of surgery we did not identify ctDNA. And then there were patients where ctDNA was not detected at baseline or pre-surgery. And next slide. And if we looked at these three subgroups and looked at long-term outcomes, what we saw was that patients who had persistent ctDNA had worse long-term outcomes, whereas patients who either had cleared or did not have ctDNA detected at both time points had better outcomes. So in summary, next slide. So one more thing that we were able to identify through this study was also looking at specific somatic variants that patients who did have ctDNA detected based on the ctDNA methylation test, was that we could identify specific mutations. And what was important is that we did identify at pre-surgery some mutations that were gained and not identified at baseline. And one of the mutations that I want to highlight is the ESR1 mutation, the D53HG mutation, which we know as an important mutation of acquired resistance to endocrine therapy. So using ctDNA, we were able to identify potential mutations of resistance to endocrine therapy that can help inform us on treatments after surgery. So next slide. So just a few takeaway messages. ctDNA can be detected in early stage hormone receptor positive breast cancer in relatively not high-risk disease using a tumor agnostic method, applying DNA methylation, and detection of ctDNA at baseline and ctDNA tumor fraction at baseline correlates with residual tumor burden after neoadjuvant treatment, and maybe could be helpful for selection of patients for neoadjuvant endocrine therapy and eventually surgical planning. And pre-surgery, and particularly ctDNA dynamics, are prognostic of long-term outcomes and could potentially be a useful term for treatment decisions after surgery. And then in addition, we're able to identify specific mutations that could help guide treatment decisions after neoadjuvant setting, and also gives us a hint that potentially ctDNA monitoring afterwards could help us also determine early recurrences. So overall, the study was a small study, but it had very clear signals and really does warrant further investigation. And I think it gives us some indication that really ctDNA testing in the neoadjuvant is likely to be a very useful tool in the future, likely along with other important tumor characteristics, as Dr. Makkar has mentioned. So with this, I will end, and thank you for your attention.
Hello, I am back to take a few questions. We've run over a bit, so let's just maybe, hopefully the presenters can stay for another 5 minutes and we'll take a few questions. The first one I have here is, when should ctDNA be implemented after surgery, chemo, or chemo, or whenever in a stage 3 patient? Does that make sense to anybody?
It does. I can take a stab or start there. I don't think we know the answer to that, honestly. It makes sense to me that you would have a baseline at some point, but whether that should be right after surgery, a lot of the data you've heard today actually sounds like the baseline before surgery might be most helpful. And by the time a patient is discussing this with their medical oncologist, we obviously would have missed that opportunity. So I personally would say that if you're going to do a series of different treatments, it probably makes sense to have a baseline before you do those, so you know where you're starting. But certainly I would at least get one maybe before starting, if I was going to go down this path, which is also the question, before I start the long-term part of the therapy, which would be the endocrine therapy for most of the patients we're talking about here.
Okay, thank you. Second one here, what is the process for ctDNA to become standard of care, and how do I get access to this test?
I can answer this one. I think for it to be standard of care, we really have to see that testing really improves patient outcomes, meaning when we identify ctDNA positivity, can we do something that will change patient outcomes eventually? So I think, or can we, or as we know, as we showed here in the neoadjuvant setting or earlier, does it change our surgical management? Does it change our treatment decisions? So as mentioned before, there are many studies ongoing looking at these. So we're very hopeful that in the very near future, these tests will become standard of care and really will improve patient outcomes and help us make treatment decisions.
Thank you. And the last one I have here is, what is known about false positive and negative rates on these tests?
So I think I'm happy to have everyone chime in on this one. From what I've seen, those numbers are under 10%, but somewhere in the 8 to 9% range from what I recall in terms of false positives. It's a little bit challenging though, because what does a false positive really mean? Does that mean that there is nothing seen on scans? Well, that's the whole reason we're doing this testing, right? Is to try to find a positive test before scans. So I think where you get those false positive numbers come from repeated testing without doing any intervention, because it logically wouldn't really make sense that you have a positive test and it gets better on its own without doing anything about it if cancer cells are really in the blood. So that's kind of what we mean by false positive right now. False negative, we don't really know it all. I mean, I think right now you would assume that those are the patients who test negative all the way along and then go on to have a metastatic recurrence. But of the false, or I guess the negative ctDNA, we know based on what you've seen that not all cancers will shed the DNA into the blood at the same rate. Not all the tests will be as sensitive to detect them. So it's really a tough number to wrap your head around because of all the technical aspects of this. And I think we're going to get the answers to these questions as this field evolves, but we're really in our infancy of understanding it.
Yeah, and I to just add to what Dr. Kruse said, which I totally agree with, I think that this question is also getting to this idea of we can have prognostic tests that give risk for a group of patients, but risk for a group of patients is different than an individual person's risk. So if you go back to the slides that Dr. Kruse showed, where you see those 4 curves, the lines that are representing patients that are alive without a recurrence at the top, and then when patients have a recurrence, the line drops down. And say there is a group of patients that are ctDNA positive, and say half of them have a recurrence. We would say, wow, that's a very high risk of recurrence. Half of those patients have a recurrence. ctDNA positivity means people are going to have a recurrence, but that's 50-50. That's tossing a coin. So that's the whole issue here, is that yes, there's a strong association with higher chance, but what does that mean for a person as an individual person? Which side of that curve are they going to be on? And that's, I think, where we need to personalize even more. And maybe it's not just ctDNA, but it's ctDNA plus other characteristics for that individual patient.
Yeah, 100%. And that's not a weird concept in our world, right? Like if we already know that even with every treatment being given perfectly, patients still have recurrences, right? In ways that we can't guess that would happen. And so I think about this in the same way. We're trying to improve the odds that a recurrence won't happen, but I wouldn't think of ctDNA as giving you a for sure answer, yes or no, because the testing is just not that good yet. And even when the testing is better, I'm not sure that anything is going to get us that true yes or no answer. There's always going to be some risk here.
Okay, well, thank you. Thank you for your time. I think we need to conclude, and I hope that this is all going to be on the LBCA website, and so any patients want to revisit what we've said, that will be, because I think it's pretty technical. I think it would be worth looking at it a second time. Anyway, just want to say goodbye to everybody. Thank you for your attendance. Thank you to the presenters.
Thank you.
Thank you.
Thank you.